I'll start with introducing the first speaker. Unfortunately, Mohamed Hani could not get here because of visa issues, I think, but Bart Toornsma, one of the co-authors of his group, is going to do the presentation. And it will be the comparison of sleeve volume between banded and non-banded sleeve gastrectomy, midterm effects on weight and food tolerance, a retrospective study. So please, Dr. Toornsma.
Thank you so much, Professor Greef, for this introduction. Indeed, I'm not Mohamed Hani, but I'm Bart Toornsma, clinical epidemiologist, and I work together with Professor Hani in the research. We did a retrospective study on the comparison of sleeve between the banded and non-banded procedures. We have no conflict of interest to report. A little bit of background, as it is the first talk of this session. We know weight regain, insufficient weight loss and weight regain occurs from the literature of around 30% after 5 to 7 years. Also, dilatation of the sleeve is happening. It's most of the causes to do revisional surgery. The higher revisional surgery rate after has been reported with weight regain for sleeve compared to bypass. It's reached up to 30%. And 4.5% of all the patients undergoing sleeve need a revision because of dilated sleeve. So we have something to do with the weight regain or insufficient weight loss and maybe also increased sleeve. The banded procedure has proposed to prevent the pouch expansion, resulting in higher weight loss compared to the non-banded procedures. However, if we need to be honest, what is also some literatures, and you can discuss the methodology of the literature, but the results showed us some studies don't see differences between the banded and the sleeve, and also some patients experience more food and eating problems. So we thought we need to research this. And also what is not done in research that much is radiology, whereby you do an assessment of the sleeve dilatation, where you can have a good volumetric report of the CT scan. So the idea is it possible to assess the volumetric of the sleeve, and can you correlate this to the possible dilatation and the amount of weight loss? So we did a retrospective study in the Medina Hospital and Medical Research Institute in Alexandria. Between 2016 and 2017, we collected the patients who had a follow-up of 4 years. They were explained both procedures, the patient can choose, and for the band they had to pay. Minor that this could be then also, well, in a positive way, a kind of bias. We tested for weight loss, sleeve volume, food tolerance, and weight regain. Pre-op workup, lab, nutritional assessment, upper GI, ultrasound, that's mandatory in Egypt for all the patients, and to assess GERD. We tested for follow-up, body mass, excess weight loss, and total weight loss, and we did something new. There is a discussion also during this conference in the literature, what is the best formula to assess weight regain? Mostly is, well, these three are the mostly used, plus they use a different type of metrics. One is percentage, one is in absolute kilograms, and one is a metrics of a BMI in an absolute number and not in the percentage. And we tested, does this has effect of the outcome? To do so, it's more my part, love it, statistics, yay. Mixed design, repeated measurement ANOVAs, and GEE to get as much as possible equal groups. Why? Because there was a ratio difference from 1 to 10 between the banded and the non-banded sleeves. So we tried to cover this as much as possible with the statistics. In total, 1528 sleeves, 152 bypass, a little bit of loss to follow up, but still above 80% after 4 years. And we used these numbers with full data sets to analyze. What does this number show? Total weight loss. You see after 4 years, 43% in the banded and 42 in the non-banded, but especially the trend in the curve is interesting what you see, what's happening. Same for excess weight loss, same trend, different formula. And if we look to the average gastric volume, and this is interesting, what you see is with the sleeve, after 4 years, the sleeve increased extremely. And if you look at the banded procedure, it increased minimum. So here is a possible first positive effect, well, second, weight loss, one, but also sleeve volume to see, hey, can we keep the patient who are normally 5% due to dilatation, need a revision, can we prevent revisional surgery by using a banded procedure? Food tolerance. Yeah, in Egypt with the Dr. Hani clinic, we love the food tolerance because it gives a good interaction of what happens, because it's a multi-dynamic approach of how a patient experience food in nausea, vomiting, the type of food or in between food. And here you see then the probably downside. Look at the clinical relevance, is a discussion what we can have, but over time the sleeve, by expanding the sleeve, you see that the food tolerance is increasing. The maximum score for food tolerance is 27, that is like ideal, I have no problems with anything. And how lower the score, the worse is the food tolerance, and a point difference is already significant worse outcome for a patient. So in this case, you almost see a point and a half. Well, a little bit of images. What does it look like when you do the cool 3D images from the CT? What I think we need to do more to get a better understanding what happens. On the A and the B, you see the ring placement, and on the C and D, you see the, after 4 years, the sleeve without ring placement, where you see the volume is increased. Conversion ratio, important to understand what we do. 0% of the patients in this cohort, and yes, it is a smaller cohort than the sleeve, had a conversion whereby 13.4% from the sleeve, and the indications were, well, the typical things that we see within sleeve: weight regain, GERD, or GERD in combination with weight regain. And if we then look postoperative, where we tested the patient, hey, is it safe to place a band, and how safe is it then in compare with a sleeve? We see that 20% of the sleeve patients develop GERD de novo A, and 18% in the banded procedure. Not significant, but still 1 in 5 get a GERD A. And if we look at the operation times, not significant difference. And if you are good in mathematics, you see that the band is even a little bit faster than the sleeve. And this is, yeah, typically because we have a 1 in 10 ratio. So yeah, if you plus a lot of more procedures with the normal sleeve, you see that on average you hit a little bit higher. Another study what we did was on average a little bit of 3 to 4 minutes longer to place the band. Hiatal hernia repair. Since all the patients got a preoperative scan, so we also knew that if a hiatal hernia repair was necessary, 6.3 in the sleeve and 5.3 in the band, not significant different, so that is more like common sense in practice. And then the weight regain. This is interesting. The discussion, I think it keeps going, and I think we don't have an answer yet, but if you use the most conservative formula with the 10% above nadir, you see that 10% of the patients in the sleeve and 3 had weight regain. But if you use other formula, the banded immediately had no weight regain anymore, and you see also by increasing other types of formula, the amount of weight regain is also losing within the sleeve. So it's also more a matter of perspective what we measure, but there is a clear trend that weight regain is less happening in banded procedure depending on the formula you take. So, limitations, always critical to ourselves. Retrospective study, well, then my epidemiology heart starts to increase a little bit, my heart rate, because it's all in the name. And we need to adapt also retrospective studies, because this is the reason why we could do things like this and why it is only in the name. In my perspective, think about the following: if you do a prospective trial, the day after, that day, yesterday was already retrospective. The only downside why this retrospective study is that we possibly have missed variables over time with the knowledge of today. So that's the limitation. And this study had not as focused to go in depth on reflux complications and associated medical problems, because that was already discussed in another paper, and otherwise it was repeating of data. And what is need to be acknowledged is the small sample. Since the patient has to pay it by themselves, you have less possibility to have a higher power, and there's a ratio 1 in 10 what you see in this. So that's something what we need to keep in mind seeing these results. So therefore larger funded studies could increase the power and could help, and I think that is necessary within the field of the banded procedures. But it shows well some promising things, because in conclusion, the banded procedure prevents pouch dilatation. So that's one of the things that you can eliminate for weight regain. However, statistical-wise, in a smaller sample, we could not test and correlate the dilatation to the rate of excess weight loss. So therefore, what is written in literature, that they see how more dilatation you have and how better the food tolerance is, it is a logical explanation that you would gain weight because you can eat more, there is more space, but we did not saw it in this study regarding excess weight loss. Well, banded associated with significant lower incidence of weight regain if you use separate type of formula. So, and then moreover, yeah, it is a sort of negative. The banded maintains significant worse between brackets, because this is open for debate. What is worse? What is the cutoff line? And is maybe just a little bit of restriction good to have a lower score, but that helps you to prevent weight regain. And since the score have 4 modules, we need to go more in depth with, for instance, a food tolerance score. What are these factors that make someone score worse, and if that is then clinical relevant in the end. That was my presentation. This is what you should have looked on the left. That was Dr. Hani, but now I'm here, and thank you for your time.